Hello, everyone. I'd like to thank the organizers for inviting me to discuss today the adjuvant treatment for early-stage ER-positive breast cancer, particularly the role of genomic signatures with San Antonio updates. So treatment decisions have changed quite a lot over the past years, where now we are in an era where we use personalized risk assessment. In the olden days, we used to rely on anatomical features of the cancer to assign stage and treatment decisions. Now we've incorporated ER/PR HER2 status, tumor grade, and one of the genomic signatures currently available. There are several, they're out there. Most of them were created to help de-escalate treatment in ER-positive disease, particularly Oncotype DX or the 21 gene recurrence score, the membrane 70 gene, Prosigna, and the PREDICT. Breast cancer index is actually interesting because it's used to determine if we could de-escalate length of endocrine therapy. Maybe we could get away with 5 years versus 10 years for people at high risk. So that may have some prediction ability. But of all the other ones, most of them are prognostic, but the recurrence score is also predictive, where it kind of tells you what to do if you're actually going to benefit from chemotherapy or not if you add to it, versus just telling you, nope, you do fine with endocrine therapy alone. So let's take a little look at the data. So we start with recurrence score. Many of you know that it is based in 21 genes, of which 16 of them are really important and mostly based on proliferation, estrogen expression, and HER2 expression. The prospective trials, both TAILOR-X and RXponder, have shifted what we used to use based on the retrospective data, the old scores of 18 and 31. They have shifted to 11 and 25. And the reason for that is because they do represent the upper confidence interval for respectively 10% and 20% risk of recurrence. So let's take a look at TAILOR-X, which was the first prospective validation of this 21 gene signature. Here, the group of interest was the group that had a score between 11 and 25, in which we would consider that kind of like intermediate, where we don't know if the addition of chemo actually means something. So if the recurrence score is under 11, odds are you're going to do it with endocrine therapy alone, and that's what these patients were assigned to. If your score is over 25, odds are you're going to need chemotherapy, high-risk disease, and that's what these patients were assigned to. And the middle group, which was literally 70% of the population enrolled in the trial, ended up being assigned to receive either endocrine therapy alone or chemotherapy prior to endocrine therapy initiation. 10,000 people were enrolled over a large period of time, and now we actually have 9-year follow-up of this trial. About 30%, about a third of the group was under 50 years of age, with a small proportion of patients being under 40. Obviously, majority of patients had ER and PR positive disease, but all of them had either one or the other. Most patients had tumors up to 3 centimeters. Obviously, everybody was node negative. Grade 3 was uncommon. Most patients had overall what we would consider low clinical risk based on MINDEC data. So the lower grade tumors, not as big, lymph node negative, etc. So when you look at 9-year follow-up data, what you can obviously see here is that the group with a recurrence score under 11 did extremely well with endocrine therapy alone. The group that had a score over 25, understandably, didn't do so well, even though they received chemotherapy, which they would have done worse without it, but obviously they are not as good of a long-term prognosis as the other group. But what was interesting is that the trial did fulfill the primary hypothesis, which was that the group that received chemotherapy was not going to do any worse or any better than the group that received endocrine therapy alone. So under 25, for the most part, based on TAILOR-X results, we don't need to add chemotherapy to a group of patients with node-negative disease and tumors up to 3 centimeters, which really is what comprised the majority of the population in the trial. However, there's a little granularity where in women less than 50 years of age, there is a difference when you add chemotherapy in scores between 16 and 20 or 21 and 25. Where between 16 and 20, there's a teeny tiny benefit from the addition of chemo. And from a score between 21 and 25, that benefit is a little higher, but overall small. I think what this suggests here is that for patients that have a more endocrine-dependent tumor, obviously the benefit of chemotherapy is more limited, But on both groups, one has to wonder if the benefit really didn't come in the form of ovarian suppression that often happens from women in women that get chemotherapy when they have ER-positive disease. So this is one unanswered question on this trial where we don't know if the chemo worked because there was something special about the chemo itself or if it worked because ovarian suppression was added. Let's take a look at RXponder, which now I'm dearfully calling TAILORx and 1 to 3 positive lymph nodes. So essentially the same population enrolled as we've seen with TAILORx, with the exception that obviously these women had 1 to 3 positive lymph nodes. 5,000 women were enrolled. Women that had a recurrence score more than 25 were booted off study and received chemotherapy followed by endocrine therapy as usual. And women with a score between 0 and 25 were then randomized to receive either endocrine therapy alone or chemotherapy followed by endocrine therapy. Stratification factors included the recurrence score itself, menopausal status, and the type of axillary staging that they had. The primary objective of this trial was to prove that what was the effect of chemotherapy in invasive disease-free survival in these patients with positive nodes and a recurrence score under 25, and if this benefit from chemotherapy depended or not on the recurrence score, considering that this is a continuous variable. So let's take a look at the patient population at large. So about 5,000 patients enrolled. 50% of the patients received a taxane-based chemotherapy, TC for either 4 or 6 cycles. The other 50% received potentially an anthracycline-based chemotherapy. Ovarian suppression was used in a minority of the women, only 60% in the endocrine arm and only 3% in the chemotherapy arm. There were a few deaths in the trial, but obviously not related to the signature, related to either stroke or some complication potentially from chemo. But be it as it may, we now have follow-up enough on the trial to yield the results. So this is the baseline characteristics. What is notable about this patient population is that they were predominantly white, predominantly postmenopausal, predominantly with a score between 14 and 25. Most women had a full axillary node dissection. Most women had only 1 node versus 2 or 3. Most women had either low or intermediate grade tumors, and most women had a tumor under 2 centimeters. When you look at invasive disease-free survival between the groups that got chemo and the group that didn't get chemo, overall, the addition of chemo was not beneficial in women with a recurrence score under 25 and 1 to 3 positive lymph nodes. When you break it down based on menopausal status, obviously there's no addition of chemotherapy benefit, but in premenopausal women, chemotherapy did make a difference. It's not a huge difference, but chemotherapy was beneficial in a group under 50 premenopausal women. The absolute difference here in distant recurrence at first sight was about 3%, contrasted to 0.3% in postmenopausal women. When you stratify by recurrence score and menopausal status, you can see that in postmenopausal women, it doesn't matter what recurrence score they have, they equally didn't benefit from the addition of chemotherapy. Whereas in premenopausal women, there was a tiny difference between the lower score had some benefit from chemotherapy, a little bit of a higher benefit if they had a higher score, but not really substantial. So in premenopausal women, even women with low scores benefited from the addition of chemotherapy. When you break it down by number of nodes and menopausal status, what you can see is that in premenopausal women, unlike postmenopausal women, we still see a separation of the curves, but in both groups, the number of nodes did not matter. Postmenopausal women, regardless of the number of nodes, didn't benefit from chemo, and premenopausal women equally benefited from chemo regardless of the number of nodes. When you look at overall survival, same trend. Premenopausal women had a little bit more benefit from the addition of chemo than postmenopausal women who had none. So how do we incorporate this into practice? So for women that are postmenopausal with either node positive or node negative disease and a recurrence score under 25, there's no benefit from the addition of chemotherapy. Over 25, recurrence score, the benefit of chemotherapy is there, although again, for postmenopausal women, that's always a little bit more limited than it is in premenopausal women. So one question that remains unanswered, I would say, in this group is, if women with up to 3 lymph nodes don't benefit from chemotherapy, is it really worth pursuing an axillary lymph node dissection in women that have positive sentinel lymph nodes? Possibly not. When we look at postmenopausal women, the plot here thickens, where in women with node-positive disease, I would argue that there's no benefiting in ordering a recurrence score test, because women with a recurrence score under 25 do benefit from chemotherapy to some extent, although we don't know if that is due to ovarian suppression, and therefore one could potentially think in somebody that has a very, very low score and not high clinical pathological characteristics, that it may be reasonable to discuss ovarian suppression with aromatase inhibitors, an alternative to chemotherapy. Although, again, if you're dealing with a younger women, higher clinical pathological risks, and a score that is a little closer to 21, then, to 25, I think it would be reasonable to go ahead with chemotherapy. But all in all, I think as a whole, women that have a node-positive disease probably don't benefit from having a recurrence score performed if they are premenopausal. In node-negative women, if they have low clinical risk and a score up to 21, I would argue that they don't benefit from chemotherapy, and endocrine therapy alone is more than enough. Between 21 and 25, I think ovarian suppression with either tamoxifen or AI is mandatory. Chemotherapy probably adds a teeny tiny little bit there. Because it is a teeny tiny little bit, I think it merits discussion. It's not set in stone. Obviously, over 25 in any group, node positive or node negative, premenopausal women would benefit from chemotherapy. In patients that have high clinical risk and score above 16, same discussion that happened here needs to happen, where there is potentially a benefit from chemotherapy, but we don't know if that benefit is secluded to ovarian suppression, and therefore one could conceive ovarian suppression with an AI or tamoxifen as an alternative to chemo in this group of patients. But again, it's not crazy to treat them with chemotherapy as well. I think one answer we don't have is, again, how much benefit do they truly derive, and if there's any benefit from the chemotherapy itself that is independent of the ovarian suppression. Now, there's another trial called MINDACT, which happened around the same time that TAILOR-X was happening. So there's also about almost 9-year follow-up on these patients right now, where essentially the idea here was to see if a genomic signature, in this case the 70 gene signature, could trump high-risk clinical characteristics in telling who benefit or not from chemotherapy. So the design of the trial is a little complicated, but we're going to focus on just the first randomization, not as much on the second and third randomization here, where the first randomization was essentially to see if what we call discordant cases, meaning patients with low clinical risk features, but high risk based on genomic signature, or women with clinically high risk disease and a low risk based on genomic signatures would benefit or not from the addition to chemotherapy. So the idea here is to see who can we spare of chemotherapy, who can we de-escalate treatment. So when you look at 9-year follow-up now, this is really not that much different than what was first seen when the trial was originally presented, where the majority of women actually didn't benefit from chemotherapy at all. Even the group that had clinically high-risk disease with genomically high-risk disease, they obviously had a lower disease-free survival at 5 and 8 years, but they got chemotherapy and their outcome is not that much different than the group that either didn't get chemo or got chemo but wasn't substantially different, because they either had low-risk clinical disease or they have low-risk genomic disease. So the discordant groups actually performed the same. The chemotherapy didn't add anything, regardless if you had low risk clinically but high risk genomically, or if you had high risk clinically and low risk genomically. And all of these women actually did quite well, not that much different than the women that had low risk all throughout. Now, when you look at distant metastasis-free survival, looking at these primary endpoints here based on chemotherapy containing anthracyclines or not containing anthracyclines, what we can see here is that there's a little bit of a difference between the type of chemotherapy, but really not much. And again, with people that have clinically high, genomic low risk treatment, again, there may be a little bit of a difference in the addition of anthracyclines in here. But overall, the conclusions on these trials were that primary endpoint continues to be met, and MINDACT really confirms that the 70 gene signature can be used to determine prognosis and possibly helping you de-escalate treatment in which a group that has clinically high but genomic low signature and or genomically high but clinically low signature could be spared of chemotherapy. With this strategy, we would estimate that about 50% of patients in which we would normally have considered chemo could now be spared of chemo and do well with endocrine therapy alone. There is an exploratory analysis looking at women under 50 and more than 50, so pre and postmenopausal. When omitting chemotherapy in postmenopausal women, it's obviously safe, but in premenopausal women, because there is a little bit of a difference there, when again, same story as the recurrence score story, the effect of the chemotherapy may be due to ovarian suppression. So again, how do we incorporate this into practice? So for women that are postmenopausal and low risk, both from a clinical point of view and genomic point of view, no chemotherapy is warranted. They do well with endocrine therapy. Women that have a high clinical risk but low mamma print risk, they do well with endocrine therapy alone as well. They don't need chemotherapy. If the mamma print risk is high, regardless if they have low risk or high risk, there is some benefit from chemotherapy. Definite benefit if the clinical risk is high, both genomically and clinically, but questionable if they have low clinical risk. Here, the benefit is minimal and needs to be discussed. In premenopausal women that have low clinical risk and low genomic risk, chemotherapy can be forgotten, regardless of number of nodes, regardless of anything else. But in women that have either a discrepancy, meaning high clinical risk with a low mamma print risk, they may still benefit from the addition of chemo, and that needs to be discussed with the caveat that, again, maybe ovarian suppression with endocrine therapy is enough. In women that have concordant high risk all throughout, chemotherapy is obviously wanted. And in women that have low clinical risk with a high mamma print risk, chemotherapy also needs to be discussed, although, again, it's unclear if they truly benefit or if ovarian suppression can be a consideration. Now, one big problem that all patients with ER-positive disease has is what we call late recurrence. The higher the clinical risk, meaning the higher the grade or the higher number of lymph nodes, the higher the chance that patients can have a recurrence beyond first 5 years. So 10, 20, 30, even 40 years down the road, all game. So one thing that has become pretty clear based on the EBCTG meta-analysis is that the highest risk group that certainly potentially benefits from endocrine therapy that is extended beyond 5 years, so either 7.5 or 10 years, is the group with positive lymph nodes. Anything above 1 lymph node would already have some significant benefit from extending endocrine therapy beyond 5 years. But now we have signatures such as the breast cancer index that not only can tell you prognostically if you are at high risk of recurrence or not, which is what all the other signatures can do, but this is a signature that the predictive ability of it was used and verified in several clinical trials now, in which a high BCI score seems to mean that people do benefit from extended endocrine therapy, whereas a low BCI score means that people with people would not benefit as much from extended endocrine therapy and do fine with 5 years only. So what we don't know is how this BCI predictive signature works in women that are not high risk, so women with node negative disease, The prognostic ability of the signature is certainly there, but the predictive ability to find out if there's a risk that is node negative that still benefits from endocrine therapy that is extended, it's unclear. So the way I use the data, and I think it's reasonable to use the data, is in people in which you're planning an extended therapy of 10 years based on positive lymph node status and high risk clinically, it's reasonable to get a BCI score to find out if one can be spared of having to take endocrine therapy beyond 5 years. And that, again, is confirmed by several of this trial, most recently by the TransAtom trial and the IDEAL trial, where patients that had a low BCI score did not benefit from extended endocrine therapy despite having positive lymph nodes. So we have now other things to consider in addition to anatomical risk and gene expression risk, which comes in the form of Ki67 and PEPI score. There were two presentations at the San Antonio Symposium that look into these two things potentially being used to also define who can benefit from endocrine therapy alone or who needs chemotherapy. The first one was the ADAPT trial, where patients here were treated in the neoadjuvant setting, and I'm going to focus on the non-chemotherapy arm here. They were treated in the neoadjuvant setting with either tamoxifen or AI for 3 weeks, and then underwent a biopsy. In women that had node negative or only one lymph node positive disease and a low recurrence score, they were assigned to get endocrine therapy alone. In women that had either node negative or minimally node positive disease with a score between 12 and 25, but a Ki67 less than 10 at that 3-week biopsy post-exposure to endocrine therapy, they were also allocated to receive endocrine therapy alone. And that is the group here that we're going to focus on this presentation. So what you can see here in these graphs is that the distant disease-free survival and overall survival was identical on the group that had a score below 25, regardless of Ki67. And in women that were premenopausal or postmenopausal, that also didn't matter. I think the only difference here is that in women that had a recurrence score that was a little bit higher and had several involved lymph nodes, up to 3 involved lymph nodes, this group actually didn't do as well as the groups that had either 0 or 1 to 2 lymph nodes. But overall, anything with a recurrence score below 25 and postmenopausal seemed to do well regardless of what really happened with that Ki67. The other thing to consider is that the majority of the patients in that trial, in those arms, actually had a Ki67 less than 10 at that 3-week biopsy post-exposure to endocrine therapy. So overall, I think there are some unanswered questions that this trial brings. One is, in the group between 12 and 25 recurrence score, with a Ki67 more than 10% after 3 weeks, would they have benefit from endocrine therapy alone? Do they really need chemo? Who knows? And do we really need to do this in patients with up to 1 or 2 positive lymph nodes and a recurrence score that's under 25? Because the 3-week Ki67 information really don't seem to have made a difference. So all in all, it's unclear if we should be changing practice based on this trial. When we look at this other neoadjuvant trial here called Alternate, and look at the recent presentation in San Antonio that focused on the chemotherapy, what we can see here is that they had initially designed a trial in which any patient with a Ki67 more than 10%, so the same cutoff that was used on the ADAPT trial, at week 4 biopsy, was then taken off the endocrine therapy neoadjuvant arms and placed on a neoadjuvant chemotherapy group. So any patient with a Ki67 more than 10 at week 4 received neoadjuvant chemo. A third received anthracyclines. The other patients got taxane or other things. They were taken to surgery. And what we see here is that this particular group, which technically was arbitrarily considered high risk, meaning because of that Ki67 more than 10%, very few patients achieved a path CR, which we know is important because not achieving a path CR may be associated with a worse long-term outcomes. So the bottom line is, between all this data, between Alternate and ADAPT, this 3 to 4 week biopsy looking at Ki67 more or higher than 10%, does not seem to be very helpful, does not seem to be a predictor of PET-CR. This is a patient population that really does not seem to have a great response to chemo no matter what. So at the end of the day, I think we just need longer follow-up on some of these trials to know if the chemotherapy actually makes a difference long-term, because short-term, it clearly did not affect this patient population. So in summary, I think we can now easily tailor chemotherapy recommendations for patients with ER-positive disease based on genomic signatures, especially the recurrence score, in which a recurrence score less than 26 in postmenopausal women definitely authorizes you to forego chemotherapy, even if positive lymph nodes up to 3 involved nodes. In premenopausal women, the jury is still out. A recurrence score under 26, it's certainly okay to forego chemotherapy in patients with node-negative disease, easily up to a score of 16 or 21. But again, that gray area in women with node-negative disease and scores between 16 and 25, it's still to be determined if ovarian suppression is okay or if chemo is actually needed. But in those women that have a recurrence score less than 25 and have lymph node positive disease, there's not even a point in ordering the test. So I wouldn't even bother, because there seems to be a benefit from chemo, either because of the menopausal status generated by chemo or because chemo works on its own. I think the BCI signature is helpful in being able to spare women with positive lymph nodes from needing extended adjuvant treatment beyond the first 5 years. And I think Ki-67 is not ready for prime time as a triage marker for chemo or endocrine therapy benefit, especially in an era of gene expression signatures. So in the interest of time, because I'm not going to have a lot of time to discuss the adjuvant endocrine therapy with CDK4/6 inhibitor trials, and this was not the scope of our talk, I'm just going to fast forward to the last slide that summarizes these trials and just briefly touch on, should we do it, should we not do it? So these are the 3 trials that were done looking at neo or adjuvant use of, looking at the adjuvant use of CDK4/6 inhibition after neo or adjuvant chemotherapy treatment for women with high-risk ER-positive disease. These are the differences between the trials. Very large trials, Penelope-B was a little smaller. 2 trials using palbociclib as a CDK4/6 inhibitor of choice, 1 using abemaciclib, here monarchy. Most patients were high risk, but the monarchy and Penelope-B patients had a lot higher risk patients than Pallas. CDK4/6 duration was 24 months for both monarchy and Pallas, but only 12 months for Penelope-B. Follow-up is very short for monarchy, but longer for Pallas and Penelope. Let's look at the results. As far as disease-free survival at 2 years, monarchy clearly showed a benefit from adding abemaciclib to endocrine therapy for 2 years in patients with high-risk disease. Whereas Pallas didn't show that, it didn't report it because they looked at 3 years. And Penelope-B showed a similar comparable benefit in the same group of high-risk patients. When you look at 3 years disease-free survival, Pallas did not show any benefit from the addition of palbociclib. But Pallas also had an issue where 42% of patients discontinued the trial early and didn't complete 24 months of treatment. When you look at Penelope-B at 3 years, the benefit here of palbociclib drops a little bit. And when you look at 4 years, there's the benefit here for abemaciclib has not been reported. It hasn't been reported for Pallas, and for Penelope-B, the addition of palbociclib benefit seems to drop quite dramatically where the curves already start closing. So this is a little troublesome, because what that means is that early on, there seems to be a benefit from the addition of CDK4/6 inhibitors, namely abemaciclib being the main one. But I think we need longer follow-up to see if this is actually going to translate into an overall survival advantage, considering that as time goes by, the curves seem to close. And that may be because once you take away CDK4/6 inhibition, you see that proliferation goes up again. So you may be just kicking the can down the road and just potentially delaying a little bit the appearance of a late relapse. So what we don't know is if long-term the addition of a CDK4/6 inhibitor is actually helpful. And we don't know if the addition of a CDK4/6 inhibitor can inhibit the appearance of late relapses, which is a huge problem in patients with even earlier stage ER-positive disease. So we don't have the answer to that yet. So I think the adoption of abemaciclib in the adjuvant setting has to be taken with caution. I probably would consider in patients that are very high risk and would have fitted criteria for Monarch E. But again, cautioning that we don't know what happens long term, and there's obviously consequences from a side effect point of view. Additionally, we still don't know what to do with those patients that are at high risk for relapse. And there are clinical trials now potentially exploring a design in which after 5 years of endocrine therapy, if patients have residual disease detected by cell-free DNA, they may be randomized to 5 years of whatever endocrine therapy they were on versus endocrine therapy with a CDK4/6 inhibitor, or maybe a novel SERD, or whatever else we may need to do with these patients. With that, I'd like to thank you for your attention. I'm open to any questions, and thank you for coming today.